Dr. Mehta. She's been at LSU since August of 2017. I just found out that she was actually recruited by Dr. Gee over here. Just looking at her work, you know, she did her medical school at Mount Sinai. She did her residency at Boston University. She was able to do a fellowship during, I believe it was your medical school period that you got to go to South Africa for fellowship research there. And then you completed, so you went to medical school at Mount Sinai, that's what I meant to say, and then residency at Boston University. Then you went to University of Pennsylvania, I believe, for a Master's of Science in I'm going to get it wrong, the public health policy. And then after that, you went back to Boston for a little bit for faculty before we charmed you here with the grace of New Orleans. Yes. So, by all means, you've taken on some great roles. You're right now currently the medical chair of the Louisiana Perinatal Quality Collaborative. I always just think of the acronym. And then the Pregnancy Associated Mortality Review, which has been a huge topic for us here in Louisiana. And we thank you for kind of starting that groundwork and look forward to kind of the things that get to come, just like we've seen in other states. And then right now you're also serving as the interim Medicaid director, I believe.
Thankfully, I'm no longer the interim Medicaid medical director, so my life has gotten a lot better.
So, by all means, I know you're getting recruited for lots more things right now, but it's my pleasure to introduce you, and I do apologize. I have to run back downstairs for a meeting, but I'm hoping to catch the evidence. So, thank you so much for coming.
Thank you. I'm wondering if maybe we can should we move up a little bit so I don't feel quite so lonely at this podium? Or are you all so comfortable?
We were trying to restrain the late people here.
That's true, but I think if they're late, we should make them awkward.
Oh, there you go. No, we make them sit in the, Louisiana, we make them sit in the front. It's called a huge,
we make
them sit in the front.
And since it's a small group, is it okay if we just do introductions? I know the whole back section, but I'd like to just meet you.
Allison Stewart.
Vanessa Thibodeau. Hi. Thanks for coming. I know it has been a long day. We've also had a long day, so try to keep things as short as possible and also keep our energy up. But I'm so grateful to Lisa and Paula for inviting us to come back. I also want to introduce two other members of our Perinatal Quality Collaborative team who are holding it down in the back with their laptops. So that's Amy Ladley. She's our program manager for the Louisiana Perinatal Quality Collaborative. And Carrie Redmond is a very experienced nurse, 28-year career in nursing, now our nurse improvement advisor for the Perinatal Quality Collaborative, so both at the Department of Health with me. So maybe we can make this more interactive and a discussion, but we had talked a little bit about some objectives for today. First of all, I don't have any financial relationships to disclose. I work in public health, so there usually are not financial relationships there. After talking with Lisa and Paula, we talked about wanting to use today to really get a grounding in why we care, what is the purpose of all of this quality work that's happening around maternal morbidity and mortality. I'd like to review some trends in severe maternal morbidity with you and our new data on maternal mortality in the state. Talk about what we can do together. So I wanted to introduce the Louisiana Perinatal Quality Collaborative and our current aim. But more importantly, or most importantly, what can we do together here at the facility level at East Jeff? East Jeff is already really leading the state in many ways in terms of your quality initiatives and your quality work. So part of the mission that I want us to have for today is less about kind of scolding you and telling you things that you should do, and more about thinking about the best of what you're doing and how you can support other facilities in New Orleans and in the state really improve our collective quality and maternal outcomes. We're going to focus on hemorrhage and hypertension, and specifically some of the recommended elements around risk assessment and quantitative blood loss and timely treatment of hypertension. Then I'm going to talk a little bit about equity, and we know that we can't really improve our outcomes without moving towards more equitable outcomes, so we're going to talk about some of the racial disparities that we see in these outcomes, and then we're going to have a little bit of a discussion and talk about some ideas that you may have for change in your system or change in the city and in the state. So if that all sounds good, we're going to start with reviewing some trends, and this can be sometimes the slowest part of the talk, so we'll try to keep us grounded in stories, and please ask me any questions as I go. Feel free to interrupt. Does this all sound okay for the next 45 minutes or so? So in August of 2018, the Louisiana Department of Health published our first maternal mortality report in about 10 years. And the work that went into this report involved collecting data from birth certificates and linking those birth certificates of babies to death certificates of mothers, and then verifying that those cases were linked to a true pregnancy and reviewing case records in a large review committee. And this maternal mortality review committee actually meets here in this room every other quarter, thanks to your hospitality. And so if you're interested in the findings that I'm describing, there are opportunities for you to be involved in our maternal mortality review committee too. We alternate our meetings here at East Jeff and in Baton Rouge every other meeting. This slide is really sobering. What you're seeing on this graph is a maternal mortality rate. So this is a number over a denominator of 100,000 births. And this data is just based on birth and death certificate data. So these cases are not verified. It's not been confirmed in a chart whether this actually happened. These are just how many pregnancy-related deaths we're seeing on death certificates that are reported to the Louisiana Department of Health. And we use a very specific definition here so we can compare our numbers to a national rate. And what you can see is that between the years 2011 and 2016, the national maternal mortality rate is climbing. And the Louisiana maternal mortality rate is also climbing, but the Louisiana maternal mortality rate is climbing faster than that national rate. And that represents a disparity in and of itself. That means that women who live in Louisiana are experiencing different maternal health outcomes than women elsewhere in the country. But within that, we are also seeing significant disparities. Black women in Louisiana are 4 times more likely to die than white women in Louisiana. And that disparity is very consistent basically anywhere you go in the country. There are some places where it's even more pronounced. So New York City, where I'm originally from, Black women are 12 times more likely to die than white women. And the difference really there is that New York City's outcomes overall are looking better than our outcomes here in Louisiana, but there is a more pronounced disparity. So we're trying to understand this issue. We're trying to understand why these outcomes could be so different for some people than others. And more importantly, how do we address those differences in risk inside the health system? Like you, I'm a practicing OBGYN. I practice at Toro on LSU faculty. And how do I translate this type of data into my daily practice as an OB? How should that affect my decisions? Should it affect my decisions? So we started diving into these deaths in our review committee. And our review committee is made up of practicing MFMs and OBGYNs from around the state, as well as nurses and a forensic pathologist. So each case that we were able to verify, and of all of the deaths that we identified on death certificates, we verified 47 that took place between 2011 and 2016. And the most common cause of pregnancy-related deaths, so these are just deaths that were thought to be directly tied to the pregnancy. We excluded cases that were a motor vehicle accident, or a drug overdose, or a homicide, or a suicide. These were 47 deaths that were directly tied to a pregnancy-related cause. Food. Hooray. Should I pause? Should we keep going?
Keep going.
Keep going.
Keep going.
So,
We'll set this up.
it's fine. I have a loud voice. I'm an OBGYN. I know how to have a loud voice sometimes. So, our leading cause of pregnancy-related death in the state, unfortunately, was hemorrhage. This was really interesting to me and to our team because in a majority of states in the U.S., the leading cause of death is thromboembolism, cardiomyopathy. In Louisiana, it is still, based on this report, obstetric hemorrhage. The good news is that we think hemorrhage is something that is particularly preventable or addressable, so I'll come back to that. The second most common cause of death is cardiomyopathy, and then after that, cardiovascular and coronary conditions. So when we looked deeper on a case-by-case basis at why women died, this review committee of practicing providers, so providers like us, these are not bureaucrats, these are not public health scientists, these are working clinicians trained in the same places that we train. These clinicians reviewed each case, and of the hemorrhage cases, when posed this question, was there some chance of this death being averted by one or more reasonable change to the patient, the family, the provider, the facility, our review committee decided that about 62% of our hemorrhage-related maternal deaths were preventable. And It's easy to look at this slide and be like, well, how did they decide that? What was that conversation like? But actually, when you look at other review committees from other states, this number is surprisingly consistent. So when you look at California's maternal mortality review, Texas's maternal mortality review, Arkansas's maternal mortality review, every single time about 60% of those hemorrhage-related deaths by different committees in different states are thought to be preventable. When we looked at the cardiomyopathy cases and the cardiovascular coronary conditions cases, similarly, a large percentage of these, about half, were always thought to be preventable. You can see that some of those cardiovascular conditions, that rate is a little bit lower, about 40% of those were considered preventable. And I'm going to describe some examples of what a case may look like, but I can tell you from having reviewed those cases myself that the cases that were not thought to be preventable tended to be someone who had very advanced cardiovascular disease. Maybe there was some documentation that she'd been counseled about the risks of pregnancy, and then perhaps she hadn't been in care and she sort of collapsed suddenly at home. And the review committee felt like, well, we don't know what we would have had to change everything about this story for this death to be prevented. On the other hand, the deaths that were thought to be preventable typically occurred within a hospital, typically within a level 3 hospital, and the providers on the review committee felt like there was something that could have gone differently with the decision making or the structure of the system that would have led to a different outcome in this case. So we looked at which buckets of these deaths really seem to be more preventable than others, and when we bunched together the cardiomyopathy deaths, the cardiovascular deaths, and the preeclampsia and eclampsia deaths, a lot of those really came down to management of hypertension. Even the women who died of cardiomyopathy, there was some elevated blood pressure leading to a sequela of untreated hypertension, and in some cases a long history of chronic hypertension leading to left ventricular dysfunction, etc., that really contributed actively to this death. Any questions so far? So if I had to kind of bucket this out, about 15% of all of our deaths were related to hemorrhage, and about 15 to 20% of all of our deaths were directly related to hypertension. When we went through each case, all of the records that we could find, for each case related to hemorrhage and hypertension, and our champion clinicians sort of reviewed this. And I have to say that some of these discussions involved arguments and a lot of spirited discussion. As you can imagine, when you stick a bunch of MFMs in a room, they're going to have lots of opinions, and there's a lot of kind of arguing about pathophysiology and stuff like that. But ultimately, even though these are practicing clinicians who understand the limitations of our clinical environments here, folks really felt that a lot of these deaths in the case of hemorrhage came down to a failure to screen for risk or an inadequate assessment of changing risk. And I'm going to give you an example case in a moment. But some of these cases, there were risk factors that weren't documented, or maybe they were documented, but then the care level never changed. Perhaps there were altered vital signs, a patient report of pain, but not that timely physician assessment at the bedside in response to those changes. The review committee noted that there was a lack of standardized policies. Remember, these deaths are occurring throughout the state in lots of different kinds of environments. They're occurring in emergency rooms, they're occurring in level 1, level 2, level 3, level 4 facilities. Noting that there was a lack of a standardized response when a patient was bleeding. And in the case of the hypertension deaths, still that failure to screen, that inadequate assessment of risk, the lack of policies, but particularly with the hypertension deaths, there were some additional factors that came up at the provider level. We noted issues around communication and care coordination, so maybe a patient gets referred to cardiology in the prenatal period, never actually gets there. Maybe the provider has assumed that she's been seen, but there's no note in the chart, no change in the medications, the echo doesn't get performed. A lack of referral or consultation, so places where our OBs and our nurses felt like, I would have really thought that this person at this point should have been referred to maternal fetal medicine, and we don't see that happening. Or how come a cardiologist wasn't called, even though this patient was in a hospital where cardiology was available, or where a critical care service was available. And as you can imagine, because you were practicing too, really seeing a lot of barriers to continuity of care. And I think that's where some of the social context of our patients comes in as well. So maybe someone has been referred but doesn't get to that scheduled visit, or they are being asked to travel far distances but they already have 3 children, and seeing these barriers to continuity of care. Now, I'm giving a grand rounds to physicians, so I did not include a slide that looked at patient-level barriers, but just because I know it'll come up when we discuss this. Some of the patient-level barriers really focused around chronic disease, so the level of chronic disease that women were bringing into their pregnancy. We didn't identify a lot of other patient-level barriers, which I was surprised by. I think I was expecting to see a lot of missed prenatal visits or not showing up on time to a hospital. Many of our patients actually had between 8 and 15 prenatal visits, so this was really about the level of medical need that some of these patients were experiencing. So now that I've reviewed some of our trends in maternal mortality, I'd like to talk about our collaborative, the Louisiana Perinatal Quality Collaborative, but I'll pause. Are there any questions about the maternal mortality data that I just presented? It's kind of depressing, but I promise it's less depressing than actually reading through these cases. And I think because I'm an OB, what has been hard about reading these cases is that I can imagine a lot of these things happening anywhere and even happening under my care. When you think about it, sometimes the level of work that we have to do to prevent a negative outcome is really working against a system, but not necessarily being helped right by the system. The system isn't necessarily designed for us to be the greatest providers we can be. We have to go out of our way sometimes to recognize that something needs to happen in a different way. So that leads me to talking about our Perinatal Quality Collaborative. So we look at this data and we know there's something wrong. Louisiana is ranking 47th out of 48 reporting states on maternal mortality. We have a lot of resources in the state. We have a lot of great providers in the state. We have way more hospitals in our state, even in our rural areas, than many other states do. So we feel like this doesn't have to be this way. Why should Louisiana be at the bottom of this pile when we have a lot of resources here? We actually have a lot of money in the state. We have a lot of infrastructure in the state. We want to do something about maternal mortality, but women die very rarely. Even though I'm showing you these high rates, remember, we're looking at a rate of 71 for every 100,000 births. So if our goal is to simply prevent a maternal death, we're not going to get very far because those events are so few and far between. So a consensus in our field is that we talk about severe maternal morbidity. And is everyone a generalist in the room? I think everyone's a generalist, right? So you may already be very familiar with this term. It's considered an unexpected outcome while pregnant, peripartum, or postpartum, and it can be an outcome that has a short or a long-term consequence. And many of us think of severe maternal morbidity as a near miss. There are two definitions of severe maternal morbidity that are out there. The first definition is recommended by ACOG and by the Joint Commission. It's super clinical. It's just a woman need 4 or more units of blood during her delivery or childbirth admission, or did she need an ICU transfer? We think of that as an indicator. We use that for case review in the hospital. The other definition has been constructed by the California Quality Collaborative and by the CDC, and it's based on administrative data and codes. And there's 21 codes, include everything from renal failure to tracheostomy, to a heart attack, to transfusion, to an ICU transfer or ventilation. And that's how we define severe maternal morbidity. Severe maternal morbidity is about 70 times more common than a death. And so we feel like we can do more quality improvement work if we focus on this outcome than if we focus on maternal mortality, because maternal mortality really is the tip of the iceberg in terms of medical issues and challenges that women may be facing, or challenges that we're facing as providers. And what you can see on this graph is just to show you that between 2016 and 2018, and these are quarters, our severe maternal morbidity rate in the state for the last 2 years has been almost perfectly stable. This number is not going up, it's not going down, which is interesting because it looks like our maternal death rate is going up. One reason for that may be that we're getting better at catching our maternal deaths, but our overall population is just stably sick or stably ill. We'll have to do more quality improvement work and more data collection to kind of understand the relationship between severe maternal morbidity and mortality. So after looking at some of that data, we decided, we is the Department of Health, but in partnership with a range of hospitals in the state, that were already engaged in improvement work. You may be familiar with the Birth Outcomes Initiative that focused on preventing early elective delivery before 39 weeks. I know you at East Jefferson have been participating in Hemorrhage initiatives sponsored by the Louisiana Hospital Association. Quality improvement work in a big group is not new to your providers and to your nurses and to your leaders here at East Jeff. So when we, meaning this whole kind of community in Louisiana of quality improvement junkies who are addicted to quality improvement and want to improve outcomes, came together and said, what is our next initiative going to be? We have a maternal mortality crisis. This thing is running in the news. Our attention is really high around this, and we have these AIM bundles that are out there that focus on hemorrhage and hypertension. Plus, these are the two leading killers in our state of women who are becoming mothers. We decided to write an AIM statement that focuses explicitly on severe maternal morbidity. So right now we have a 31 hospital initiative. We launched our initiative in August of 2018 on the same day as when our maternal mortality report came out. And these 31 hospitals are going to achieve this AIM together. We are going to achieve a 20% reduction in severe maternal morbidity. We don't think we can change all severe maternal morbidity just by focusing on hemorrhage and hypertension. So we are just focusing on women who experience hemorrhage and who experience severe hypertension in our participating hospitals in the next 12 months. So we are going to reduce severe maternal morbidity in women who bleed or who have severe hypertension by 20% in participating hospitals in the next 12 months. And because we know that Black women are 4 times more likely to die, because we don't think that that has to be that way, we're going to try and narrow the Black-white disparity in that outcome too. And we're going to talk a little bit about whether we think that's possible or not based on some data that we have. So 31 hospitals signed up. Some of them are super ready. Others of them are really trying to power through this initiative. It's been a very strenuous initiative in that we're requiring monthly participation. So thank you to your awesome team in the back section over there for really showing some commitment, and also thank you to you as physician champions for being here and for showing commitment too. In order to get to this outcome, we think that we have to attack the problem from multiple different directions. So obviously we need to implement our AIM, hemorrhage, and hypertension bundles, and I'm going to talk more about that. That really is the clinical part. But we also know from our early elective delivery initiative, from the Institute for Healthcare Improvement, from AIM, that we need to do other things in order to really see these outcomes change. We need to have a relationship with our patients who may be experiencing